Good day, dear students. I am Chmitronov Sergey Nikolaevich, the head of Human Anatomy Department in Samara State Medical University. And now we will talk about particular arthosyndesmology, and you will listen second lecture about particular arthosyndesmology. And next, I'll show you the plan of our lecture. First, we'll talk about joints of pelvic bones. Next, we'll talk about iliofemoral joint. After, we will talk knee joint, ankle joint, and joints of the foot. The joints of the pelvic bones. The joints of the pelvic bones in man reflect the development of these bones in association with the changing functional condition in the process of phylogenesis. As mentioned above, the pelvis of quadrupeds is not subject to heavy load because of the horizontal position of the animals. With the change to an upright position, the human pelvis became a support for viscera and the place where the weight is transferred from the trunk to the lower limbs, as a consequence of which it has to sustain a great load. The separate bones united by the cartilage fuse to form a single bone structure, the hip bone, so that the synchondrosis is converted to synostosis. The synchondrosis between both pelvic bones, however, does not develop into synostosis but becomes hemiarthrosis. You may see hemiarthrosis on this page. It's named symphysis pubic. The articulations of both pelvic bones with the sacrum requiring a combination of mobility and strength acquires the form of a true joint diarthrosis, strengthened rarely by ligaments, syndesmosis. As a result, all types of joints reflecting the successive developmental stages of the skeleton and encountered in the human pelvis, synarthrosis in the form of the syndesmosis ligaments, synchondrosis between the separate part of hip bone, and synostosis after their fusion to form the hip bone, hemiarthrosis, the pubic symphysis, and diarthrosis, the sacroiliac joint. The total range of movement between the pelvic bones is very small, 4 to 10 degrees. Sacroiliac joint, you may see it on this page here, is formed by continuous articular surfaces of the sacrum and ilium. These surfaces are congruous and covered by a thin layer of fibrous cartilage. The sacrum is wedged between the two iliac bones, as a result of which it cannot be displaced entirely and downward by the weight of the trunk until the branching of the pelvic vault are separated. The sacrum is therefore the key of the pelvis. It's called by Lescaft. This key is strengthened by the interosseous sacroiliac ligaments, ligamenta sacroiliaca interossea. You may see this ligament here. This ligament stretching in the form of short bundles between the iliac tuberosity and the sacrum. They are the strongest ligaments in the human body. They serve as an axis on which movement at the sacroiliac joint occurs. The joint is strengthened also by other ligaments connecting the sacrum of the ilium, anteriorly by the anterosacroiliac ligaments. You may see these ligaments on this picture too. Ligamenta sacroiliaca ventralia, it's in Latin, which are tightly fused with the capsule, and posteriorly by the posterior sacroiliac ligaments, ligamenta sacroiliaca dorsalia. running downward from the superior and inferior posterior iliac spine to the sacral vertebra and by iliolumbar ligament, you may see on this picture too, stretch between the transverse crosses of the fifth lumbar vertebra to the iliac crest. The pubic symphysis, you may see on this picture, symphysis pubica, it's in Latin, is on the midline and joins the pubic bones. A fibrocartilaginous plate, the interpubic disc, discus interpubicus, it's in Latin, is lodged between the faces of symphysialis of these bones, which face each other and are covered with hyaline cartilage. A narrow synovial slit-like cavity is seen in this disc nearer to this posterior surface, hemiarthrosis, usually from the age of 7 years. The pubic symphysis is strengthened by thick periosteum and ligaments, above by a superior pubic ligament, ligamentum pubicum superior, and below by the acute ligament, ligamentum arcuatum pubis, which rounds off the subpubic angles, angulus subpubicus. The sacrotuberal and sacrospinal ligaments, you may see these ligaments on this picture, are two strong interosseous ligaments connecting on each side to hip bone with the sacrum. The sacrotuberous ligament, ligamentum sacrotuberale, stretch from ischial tuberosity, you may see on this picture, to the lateral borders of sacrum and coccyx. It partly continues with the vertically stretched superficial bundles, the dorsosacroiliac ligaments, with which it reaches the superior posterior iliac spine. The sacrospinal ligament, ligamentum sacrospinale, you may see at this picture, originates at the ischial spine, crosses the sacrotuberal ligament, and it attached to the lateral border of the lower part of the sacrum and the upper part of the coccyx. The ligament described contribute the formation of the bone framework of the pelvis in the posterior inferior segment and transform the greater and lesser sciatic notch to the greater and lesser sciatic foramina. You may see this foramina on this picture. This is foramen ischiaticum majus, greater, and this is foramen ischiaticum minus, lesser. So the obturator membrane, you may see it on this picture, membrana obturatoria, it's in Latin, is fibrous plate closing the obturator foramen of the pelvis except in its superlateral part. It is attached to the edge of obturator sulcus on the pubis found here and thus converts the sulcus to the obturator canal, canalis obturatorius, transmitting the obturator vessels and nerves. Next we will talk about pelvis as a whole structure. Both hip bones unite with each other and with the sacrum to form a bony ring. The pelvis, which connects the trunk with the three lower limbs, and at the same time encloses a cavity containing the visceral organs. The bone ring is divided in two parts. A wider upper part, the greater pelvis, pelvis major, and a narrower lower part, the lesser true pelvis, pelvis minor, it's in Latin. The greater pelvis is bounded only laterally by ilia, which are rather widely spread out. It has no bony walls in front, and its deficiency in its posterior boundary is filled by the lumbar vertebra. The superior boundary of the lesser pelvis, separating it from the greater pelvis, is the terminal line. You may see the terminal line here. It's the border between greater and lesser pelvis. The superior boundary of the lesser pelvis, separating it from the greater pelvis, is terminal line, formed by premontorium, acute line of the ilia, pectines of pubic bones, and superior border of the pubic symphysis. The opening thus bounded is called the pelvic inlet, aperture of pelvis superior. The cavity of the true pelvis, cavum pelvis, is below the inlet. Anteriorly, the wall of the pelvic cavity for the pubic bones on their articulations is very short. In contrast, posteriorly the wall is long and is formed by sacrum and coccyx. The lateral walls of the true pelvis are formed at areas of the hip bones corresponding to the acetabuli and by the ischiac bones together with the ligaments reaching them from the sacrum. Below the pelvic cavity ends and the pelvic outlet apertura pelvis inferior. The distance between the two superior anterior iliac spines, the interspinosus diameter, distantia spinalum. You may see this distance on this picture. The distance between two crista iliaca is intercristal diameter, distantia cristalum. The distance between the two greater trochanters, intertrochanteric diameter, distantia intertrochanterica, measuring 30-32 centimeters. After that, the external anterior-posterior diameter is measured. The distance from symphysis to the depression between the last lumbar and first sacral vertebra, you may see on the lower picture, to determine the true anterior-posterior diameter of the pelvis is conjugata vera. You may see on this picture from this point to this point. It's measuring 9 to 10 centimeters are subtracted from the value of the external anterior-posterior diameter. The result will be a steptic conjugate diameter, conjugata vera sine gynecologica, which is usually 11 centimeters. So you may see conjugata anatomica, it's upper conjugata. You also may see conjugata diagonalis and conjugata gynecologica, which usually 11 centimeters. The distance between the anterior and posterior superior spina of the iliac bones is lateral conjugate. It measures 14 to 15 centimeters. To determine the transverse diameter of the pelvic inlet, the intercristal diameter is divided by 2 or 15 centimeters are subtracted from its value. So by connecting the central points of the anterior-posterior diameter of the pelvis, including the outlet and inlet, the axis of the pelvis is drawn in the form of an anteriorly concave line passing through the center of the pelvic cavity. In its natural position, the pelvis is markedly inclined anteriorly, inclination pelvis, so that the plane of the pelvic inlet of the anatomical conjugate meets the horizontal plane at the angle which is larger in females and than in males You may see this angle on this picture. Inclination of the pelvis is due to the upright position of the human body. This erect position also causes the curving of the spine, with which the pelvis is directly connected. The angle of the inclination of the pelvis range between 75 and 55 degrees. When a person is sitting, the pelvis takes a almost horizontal position, as a consequence of which the angle measures only 7 degrees. The shape and size of pelvis reflect its function. In quadrupeds, the pelvis, which does not have to bear the weight of the whole superincumbent body and support the viscera, is relatively small and has a narrow elongated front with a sharply predominant anterior-posterior diameter of the true. In anthropoid, in whom the upper and the lower limbs are distinguished, the pelvis is much wider and shorter, but the anterior-posterior diameter still predominates over the transverse diameter. As a result, the contours of the pelvis inlet resemble the A's of hearts, or as is generally expressed, is heart-shaped chordate pelvis. Finally, in the erect human being, the pelvis is shorter and wider, so the both diameters are almost equal in males, whereas in females the transverse diameter is even larger than the anterior-posterior diameter, because the pelvis performs a special function associated with childbearing and the act of labor. The pelvis of the Neanderthals exhibits the human features which indicates they walked erect. However, it's somewhat narrower than the pelvis of modern man. In reflection of this evolutionary process and man's ontogenesis, the pelvis in the embryo is narrow, like that of quadrupeds. In the newborn, it resembles the pelvis of anthropoids, anthropoid pelvis, and finally, with the mastery of walking erect, it gradually acquires the shape characteristics of the human pelvis. Sex differences begin to be manifested most sharply with the onset of puberty. They consist in the following. The bones of the female pelvis are generally thinner and smoother than those of the male pelvis. The iliac wings are spread out, out more widely in females, as a result of which the distance between the spines and crests um, is greater. The inlet of the pelvis is transversely oval in females and rather longitudinally oval in males. The promontory projects farther forward in male pelvis. The male sacrum is relatively narrow and more concave. The female sacrum, in contrast, is relatively wider but at the same time flatter. The outlet of the pelvis is much narrower in males. In females, the ischial tuberosities are farther apart, and the protrusion of the coccyx to the front is less. The junction of the inferior pubic rami has the shape of an arch in a well-development in female pelvis, but forms an acute angle in male pelvis. The cavity of the true pelvis is definitely funnel-shaped in males, but less funnel-shaped and more cylindrical in females. In general, the male pelvis is higher and narrower, while the female pelvis is shorter, wider, and roomier. So you may see on these pictures male and female pelvis. Also, you can see this pelvis on this picture, male and female. Next we will talk about hip joint. The hip joint, Articulatio coxae in Latin, you may see on this picture, is formed by a cup-like acetabulum of the hip bone by its fascias lunata, to be more precise, and the femoral head fitting into it. Its fibrocartilaginous ring, labrum acetabuli, you may see on this picture, here. A fibrocartilaginous ring, labrum acetabuli, is attached to the whole rim of the acetabulum and makes the cavity deeper so that its depth is more than a half of spheroid. The fibrocartilaginous rim bridges the acetabular notch and forms the transverse ligament of the acetabulum. Ligamentum transversum acetabulae. The acetabulum is covered with hyaline articular cartilage only in the area of the lanate surface, while the acetabular fossa is filled with loose fatty tissue at the base of the ligament of the femoral head. The surface of the femoral head, articulating with the acetabulum, forms in general 2/3 of spheroid. It's covered with hyaline cartilage, with exception of the fovea capitis, giving attachment to the ligament of the head. You may see the ligament of the head in this picture. The articular capsule of the hip joint is attached along the whole rim of the acetabulum. In the region of the acetabular notch, it fuses with the transverse ligament of the acetabulum, leaving a free opening between this ligament and this edge of the notch. Airtightness of the joint here is provided by a synovial membrane covering the ligament of the head. The articular capsule is attached to the femur in front along the entire distance in the intertrochanteric line, and behind to the femoral neck parallel to and middle of the intertrochanteric crest. The hip joint has two other interarticular ligaments, the above-mentioned transverse ligament of the acetabulum and the ligament of the head, ligamentum capitis femoris, whose base is attached to the edge of the acetabular notch and to the transverse ligament of the acetabulum. The apex is attached to the fovea capitis femoris. The ligament of the head is covered by a synovial sheath rising over it from the floor of the acetabulum. It is an elastic padding which absorbs the shocks experienced by the joint and transmits the vessels to the femoral head. You may see it on this picture. Small vessels and ligament. That's why the head does not necrotize in fractures, because the ligament has elastic structure. The hip joint is a ball and socket joint of the limited type, cartilaginous joint, and therefore permits movement through not as freely as a free balance socket joint, on three main axes, frontal, sagittal, and vertical. Circumduction is also possible. Flexion and extension of the lower limb occur on the frontal axis. The first of these two movements is forward flexion because there is no tension of fibrous capsule, which has no attachment to the femoral neck at the back. Flexion is greatest 120 degrees when the knee is bent so that the thigh can be brought against the interior abdominal wall. When the knee is in extension, flexion of the limb is limited via um, 87 degrees by tension of the muscle of the posterior surface of the thigh. When the knee is bent, these muscles are relaxed. Extension of a flexed limb is possible to vertical position. Further movement to the back, posterior flexion, is greatly limited to about 90 degrees by tension of the iliofemoral ligament. If despite this we extend the limb still further, um, this is accomplished through movement at the contralateral hip joint. Movement above the sagittal axis consists in abduction of the limb or limbs where they are uh, drawn apart at the same time laterally, and in adduction when the limb moves to the midline. Abduction is possible to 70-75 degrees. Medial and lateral rotation of the limb on vertical axis has a range of 90 degrees. The external ligaments of the joint are arranged in accordance with three main pivotal axes. Three longitudinal ligaments, ligamenta iliofemorale, pubofemorale, and ischiofemorale, which pass perpendicular to the horizontal axis, frontal and sagittal, and one circular, zona orbicularis, which is perpendicular to vertical axis. Iliofemoral ligament, you may see on this picture, is on the anterior aspect of the joint. Its apex is attached to the anterior inferior iliac spine and its widened base to the trochanteric line. It resists extension and prevents the body from falling backward when walking erect. As this explains the high development of Bertin's ligament in man. It's the strongest ligament in the human body and can withstand a load of 300 kg. The pubofemoral ligament, ligamentum pubofemorale, you may see on this picture, is on the inferior medial aspect of the joint. It stretches from the pubis to the lesser trochanter and blends with the capsule. It resists abduction and checks lateral rotation. The ischiofemoral ligament begins on the posterior aspect of the joint at the acetabular rim, and the region of the ischium passes laterally and upward over the femoral neck, blends with the capsule and attaches to the anterior edge of the greater trochanter. It limits medial rotation of the thigh, and together with the lateral part of Bertin ligament resists adduction. The orbicular zone, zona orbicularis, consists of circular fibers in the deep layers of the articular capsule under the longitudinal ligaments. These fibers embrace the femoral neck like a loop and attach above to the bone under the anterior varus iliac spine. The circular arrangement of the orbicular zone corresponds to the rotational movements of the thigh. You may see the orbicular zone deeper um, on this picture of this capsule. In living persons, the ligaments do not stretch maxillary because movements are checked to the certain degree by the tension of the muscles around the joint. All the described movements of the lower limb at the hip joint may take place when the limb is relieved of the weight of the body, as occurs, for example, when a person is standing on the other limb. Forward and backward flexion of the limb also occurs in walking or running, when the body is supported by alternating limbs, while the limb that is freed or the weight makes a forward motion. When the lower limbs are fastened, stand fast in one spot, movement of the hip bone and the hip joint may take place only with movement of the whole upper part of the body, as it occurs, for instance, when a person bends a body in a body and unbends while the limbs rest on the ground. The same happens when a person rises from a supine position. The lower limbs lie on the plane, while the pelvis with the trunk rises and moves at the hip joints. The great number of ligaments and the more pronounced curvature and congruence of the articulatic surface of the hip joint as compared to the shoulder joint make movements at the hip joint less free than those in the shoulder. Next, we will talk about knee joint. Articulatio genus, it's in Latin, is the largest and at the same time and most structurally complicated joint in the body. This is due to the fact that it's the site of articulation at the longest levels of the lower limbs, the femur and leg bones, which are characterized by the largest range of movements made in walking. Three bones form the knee joint: the lower end of the femur, the upper end of the tibia, and the patella, kneecap. The articular surfaces of the femoral condyles uniting with the tibia are convex in the transverse and sagittal directions, and there are segments of an ellipsoid. The tibial fascias articularis, articulating with the femoral condyles, consist of two shallow facets covered with hyaline cartilage. These facets are complemented by two interarticular cartilage, lateral and medial semilunar cartilage, menisci. You may see menisci, meniscus lateralis et medialis, interposed between the femoral condyles and articular surfaces of the tibia. Each meniscus is trihedral plate bent along the edge. The thickened peripheral edge is attached to the articular capsule, while the sharpened edge directed into the joint is free. The lateral meniscus is bent more than medial. The lateral is rather crescent-shaped, while the lateral meniscus is nearly circular. The ends of both menisci are attached anteriorly and posteriorly to the intercondylar eminence. The fibrous bundle, the transverse ligament of the knee, you may see the transverse ligament here, stretch in front between the menisci. The articular capsule is attached at some distance from the edge of the femoral, tibial and patellar articular surface. On the femur, therefore, it stretches in front upward bypassing the fascias patellaris. On the sides, it passes between the condyles and epicondyles, with the latter left outside the capsule for attachment of muscles and ligaments, and at the back it descends to the edge of the condylar articular surface. In addition, in front the synovial membrane forms the large recess, the suprapatellar bursa, you may see this bursa here. On this picture you may see femur, ligamentum transversum genus, kneecap, ligamentum patellae. So, bursa suprapatellaris, extending rather high between the femur and the quadriceps muscle of the thigh. Sometimes the suprapatellar bursa may not communicate with the knee joint and may be separated from it. On the tibia, the capsule is attached to the edges of the articular surfaces of the condyles. On the patella, it's attached to the edges of the cartilaginous surface and as a result seems to be inserted into frame formed by the anterior part of the capsule. The medial and lateral ligaments are stretched on the side of the joint perpendicular to the frontal axis. Ligamentum collaterale tibiale and ligamentum collaterale fibulare. Ligamentum collaterale tibiale stretch on the medial side from the medial epicondyle of the femur to the edge of the tibia and fuse with the capsule and the medial meniscus. Ligamentum collaterale laterale, you may see on this picture, passes on the lateral side between the lateral epicondyle and the fibular head. The fibular collateral ligament has the shape of a round curve, which is not attached to the articular capsule, but is separated from it by a pad of fat. On the posterior aspect of the knee joint capsule are two ligaments merging with its posterior wall. The arcuate ligament of the knee, ligamentum popliteum arcuatum, and the oblique ligament of the knee, ligamentum popliteum obliquum. The tendon of the quadratus muscle of the thigh is on the anterior aspect of the knee joint. It includes the patella as a sesamoid bone and is then continuous with a thick and strong patellar ligament. You may see this ligament on this picture. Which passes downward from the apex of the patella and is attached to the tuberosity of tibia. This ligament is separated from the articular capsule by a certain amount of fatty tissue, which also serves as foundation for the alar folds, plicae alaris, of the synovial membrane described below. On this side of the patella, expansions of the tendon of the quadriceps muscle form the lateral and medial patellar retinacula. You may see retinacula here, laterally of patella. So, retinacula patella laterale et mediale, it's in Latin, made up of vertical and horizontal bundles. The vertical bundles are attached to the tibial condyles, the horizontal to both femoral epicondyles. These bundles hold the patella in place during movement, beside the extra-articular ligaments described above. The knee joint has two intra-articular ligaments called coxae ligaments. You may see coxae ligaments here and here. Ligamentum cruzatum anterior and ligamentum cruzatum posterior. Anterior ligament connects the medial surface of the lateral condyle of the femur with the area intercondylaris anterior tibia. The other, the posterior ligament, passes from the lateral surface of the medial femoral condyle to the area intercondylaris posterior of the tibia. The synovial membrane lining the capsule covers the coxae ligaments projected into the joint and forms two fat contains alar folds, plicae alaris, of the anterior wall of the joint below the patella. These folds become adjusted to the articular surfaces with each position of the knee joint by filling the spaces between them. Covering below they are continuous with the unpaired infrapatellar synovial fold, which is attached to the anterior edge of the intercondylar notch of the femur. So these ligaments also divide the cavity of the knee joint into the anterior and posterior parts. Two types of movement occur at the knee joint: flexion and extension, and then rotation. The knee is a typical condylar joint. Flexion and extension take place on the frontal axis, passing through the femoral condyles. The range of flexion is considerable and it is possible to an angle of 40 degrees. Extension occurs until the thigh and leg are on line uh, 180 degrees, after which it's arrested because the condyles of the femur abut against the tibia. As a result, the menisci are compressed, the collateral and coxae ligaments strongly tightened, and the leg and thick locked in a single structure. In flexion, the menisci straighten out, while the collateral ligaments relax because the points of their attachments come closer to each other. Rotation of the longitudinal axis becomes possible when the knee is flexed. The cruciate ligaments restrict medial rotation of the leg, but on the contrary, relax in lateral rotation, in which instance movement is limited by the lateral ligaments. In rotation, the greatest range of movements take place in the region of the lateral condyle because the collateral fibular ligament, which does not merge with the articular capsule, relaxes more than the collateral tibial ligament. During rotation, the menisci glide on the articular surface on the tibia. In addition to indicated role of the cruciate ligaments in rotational movement, they also affect flexion and extension by holding the bones in a definite position and at the same time limiting movement. The structure and arrangement of the ligaments of knee joint in men facilitate in maintains of an upright position for a long period of time. Joints between uh, leg bones and foot. Now we will talk about these joints. Um, the talocrural or ankle joint. You may see this joint on these pictures. The talocrural or ankle joint is formed by the articular surfaces of the distal ends of both leg bones, which feed over the trochlea of the talus like a fork. The lower articular surface of the tibia articulatis with the fascius articularis superior of the trochlea, while the articular surface of the malleoli articulate with the articular surface of the side of the talus. You may see these articular facets of this picture. This is um, fasces articularis inferior tibia, fasces articularis malleolaris of ankles, and also you may see the articular facets of talar bone. The articular capsule is attached to the cartilaginous margin of the articular surfaces and covers part of the neck of the talus in front. Accessory ligaments run on the sides of the joint from the malleoli to the adjacent tarsal bones. The medial deltoid ligament here has the appearance of a plate resembling the Greek letter delta in shape. The lateral ligament is formed by three bundles passing from the lateral malleolus into three different directions. Forward, the anterior talofibular ligament, downward, the calcaneofibular ligament, and backward, the posterior talofibular ligament. In the character of its structure, the ankle joint is a hinge joint. Movement takes place on the frontal axis passing through the trochlea of the talus, during which the foot is now raised with the toes upward dorsiflexion and lowered plantar flexion. The movement occurs in a range 60-66 degrees. Slight side movements can also be made in plantar flexion because in this position the narrower posterior part of the trochlea of the talus is not grasped as tightly by the fork formed by the leg bones. In dorsiflexion, in contrast, this movement is absolutely impossible because the trochlea is held securely by the fork formed by the malleoli. tension of the Achilles tendon and the anterior or the posterior surface of the joint, and frequent abutment of the tibia against the neck of the talus also contribute to limitation of dorsiflexion. The posterior border of the tibia may also push against the posterior process of the talus in the last movement of plantar flexion. The following four joints are distinguished in the articulations between the tarsal bones and intertarsal bones. Subtalar joint, you may see this joint on this picture here. Talo-calcaneonavicular joint, you may see here, this joint. The calcaneo-cuboid joint, you may see it on this picture. And cuneo-navicular joints. Cuneo-navicular joint. The subtalar joint is formed by the posterior articular facets of the talus and calcaneus, which represent segments of cylindrical surface. They are surrounded by articular capsule, strengthened the side by accessory ligaments. The cavity does not communicate with any other joint. The tau-calcaneonavicular joint is to the front of the subtalar joint, and it's formed by an almost spherical talus and a corresponding articular socket formed by a navicular bone. The articular facet on the sustentaculum tali of the calcaneus and the plantar calcaneonavicular ligament, filling the space between the sustentaculum and the posterior margin of the navicular bone and containing in its thickness a layer of fibrous cartilage, fibrocartilago navicularis. The articular capsule is attached directly to the edge of the articular surfaces, and it's strengthened on the dorsal surface by a navicular ligament. The plantar calcaneonavicular ligament mentioned above serves as an accessory ligament of the plantar aspect. Between the two joints mentioned, there are a bony canal, sinus tarsi. You may see this structure of this picture, which lodges a strong interosseous talocalcaneal ligament. You may see this ligament here in this space, sinus tarsi. Besides the ligament, the sinus also contains some loose fat in which an inconstant synovial bursa sinus tarsi may be found. The calcaneo-cuboid joint, you may see on this picture, is formed by articular facets on the opposed surfaces of the calcaneus and cuboid bone. It has a tightly stretched capsule strengthened by ligaments blinding the articulating bones of the dorsal and plantar aspects. The cavity does not communicate with any other joint. The calcaneo-cuboid joint takes part in movement occurring the subtalar and tau-calcaneonavicular joints by increasing their range. The calcaneo-cuboid joint together with the tau-navicular joint are often described under the common name transverse tarsal joint, Chopard joint. Two joints are formed one transverse joints. First is calcaneo-cuboidum and second is tau-naviculare. And you may see two these joints form one functional joint, Chopard joint, Articulatio tarsi transversa. An examination of a section of the common line of Chopard joint show it to resemble a Latin letter S. You may see this letter S-shaped form this joint, Articulatio tarsi transversa. Um, so, in addition to ligaments straighten the calcaneocuboid and talonavicular joints separately, chopper joint has a ligament common to both these joints, which is of great particular importance. Um, this is bifurcate ligament, ligamentum bifurcatum. You may see this ligament here, which arises posteriorly on the superior border of the calcaneus and then separates in two parts, one of which, the calcaneonavicular ligament, is attached to the posterior lateral border of the navicular bone, while the other, the calcaneocuboid ligament, is attached to the dorsal surface of cuboid bone. This short but strong ligament is the key of chopper joint. This is key of chopper joint, since only when this ligament has been cut can the articular surfaces be drawn widely apart at the operation for the extra-articulation of the foot of this joint. The cuneo-navicular joint, you may see this joint here on this picture, is formed by articulation of the posterior articular surfaces of the cuneiform bones with the three facets on the distal articular surface of the navicular bone. All these articular surfaces are enclosed in a single common capsule, and the joint cavity extends between the opposed surfaces of the cuneiform bones. Between the medial and intermediate cuneiform bones, the cavity often communicates with the second and third tarsometatarsal joints. The cuneo-navicular joint is strained on the dorsal and plantar surfaces by a ligament which straight between the bones forming these joints are designated a coupling. Movements at the intertarsal joints consist firstly in rotation of the calcaneus together with the navicular bone and anterior distal end of the foot on the sagittal axis within a range 55 degrees, entering the head of the talus on the dorsal surface and leaving through the side of the calcaneus on the plantar surface. In medial rotation of the foot pronation, uh, its lateral border is raised, while the dorsal surface faces medially. In contrast, in lateral rotation, supination, the medial border is raised, and the dorsal surface of the foot faces laterally. In addition, abduction and adduction on the vertical axis can take place with the tip of the foot displaced medially or laterally from midline. Finally, dorsal and plantar flexion can occur on the frontal axis. Movement on all the axes as also takes place at calcaneonavicular joint, which is a complex spheroid joint. The extent of movement is slight, and the movements are usually combined so that during supination, the anterior part of the foot is also adducted and slight plantar flexion occurs, or on the contrary, pronation is attended by adduction and dorsiflexion. On the whole, the ankle joint, together with the intertarsal joints, permits freedom of the movement of the foot as multi-axillary joint. The tarsometatarsal joints, you may see in red, tarsometatarsal joints on this picture, known in the aggregate as a Lisfranc joint, unite the second row of the tarsal bones with the metatarsal. They are formed by the articular surfaces of the distal aspects of the three cuneiform bones and the cuboid bone, with which the corresponding articular surfaces of the bases of the five metatarsal bones articulate. The tarsometatarsal joints are typical tied joints, the slight movements at which lends elasticity to the arch of the foot. The articulations of the first metatarsal with the medial cuneiform bone, articulations of the second and third metatarsal with the corresponding cuneiform bones. The articulation of the fourth and fifth metatarsal with cuboid have their own articular capsules. In general, the line of the articulation compelvic lisfranc joint forms an arch with quadrangular projection to the back corresponding to the base of the second metatarsal bone. The tarsal-metatarsal joints are straightened by dorsal plantar and interosseous ligaments. The intermetatarsal joints, articulationes intermetatarsae, you may see on this picture here, are formed by the opposed surfaces of the metatarsal bones. Their joint cavities often communicate with the cavity of the metatarsal and tarsal-metatarsal joints. The joints are strengthened by the transverse ligamenta metatarsia dorsale, ligamenta metatarsia plantaria, and interossea. Joints of the toe bones. Metatarsophalangeal joints between the heads of the metatarsals and the bases of the proximal phalanges resemble the analogous joints of the hand and their structure and ligamentous apparatus. Movements at the joints are in general the same as those at the corresponding joints of the hand, but they are limited. Except for the slight adduction and abduction of the toes, only dorsal plantar and plantar flexion of all the toes together occurs. The range of dorsiflexion in the foot is larger than the range of plantar flexion. This is the opposite of the situation in the hand. The interphalangeal joints, you may see on this picture, Articulationes interphalangeae, do not differ in structure from the similar joint of the hand. It should be pointed out that synostosis of the distal and middle phalanges of the little toe is often encountered. The foot is whole. Next we talk about this. So now we repeat, this line is tarsal articulatio tarsi transversa. You know, it's Chopard joint and key of Chopard joint, and in red line, red arrows point the lisfranc joint and lisfranc key. It's a ligament between medial cuneiform bone and second metatarsal bone. This arrow point on this key, lisfranc key. So next we talk about foot as whole. The foot is constructed and functions as a silent mobile arch. The foot of all animals, including anthropoids, is devoid of the arch structure that characterizes man as a result of his erect position, a structure developed as a result of the new functional requirements by the human foot. The increased load experienced by the foot in the upright position of the body and the reduced surface of support in combination with the economy of building material and the strength of the whole construction. The complex of the foot bones connected with tight joints, which permits almost no movement, forms the hard foundation of the foot consisting of 10 bones: the navicular bone, medial, intermediate, and lateral cuneiform bones, the cuboid bone, and first, second, third, fourth, and 5 metatarsal bones. Among the ligaments, the long plantar ligament plays a decisive role in straightening the arch of the foot. It arises from the inferior surface of the calcaneus stretched forward and attached by its deep fibers to the tuberosity of cuboid bone and by superficial fibers to the base of the metacarpals. Braiding the sulcus of the cuboid bone, the long peroneal ligament converts it into osteofibrosis canal through which the tendon of the long peroneal muscle passes. 5 longitudinal arches and 1 transverse arch, you may see this arch on this picture, are distinguished in the whole arch structure of the foot. The longitudinal arches begin from the one point on the calcaneus and diverge anteriorly along the upwardly convex rays corresponding to the 5 rays of the foot. Each longitudinal arch is therefore made up of metatarsal bone, the first in the first arch, the second in the second arch, etc. And the parts of the carpal bones located between and the tuberosity of the calcaneus. The sternitaculum tali plays an important role in the formation of the first arch. The second arch is the longest and highest of all longitudinal arches. The longitudinal arch joined in the anterior part in the form of a parabola from the transverse arch of the foot. The bony arch are maintained by shape of the bones forming them and by the muscles and fascia. The muscles are active tightening devices holding the arches. The transverse arch is held in particular by the transverse ligaments of the sole, the obliquely stretched tendons of the long peroneum and posterior tibial muscles, and the transverse head of the adductor muscles of great toe. The longitudinally arranged muscles shorten the foot, while the oblique and transverse muscles make it narrower. Such a two-way effect exerted by the tightening muscles preserves the arch form of the foot, which acts as a spring and lends elasticity to the gait. When the apparatus describes loses its strength, the foot becomes flat. The resulting fatty structure, called flat foot, is painful. According to some data, the role of passive factors, bones and ligaments, in maintaining the arch is no less, and may even be greater than the role of the active factors. You may see the arch, transverse arch, longitudinal arch, on this picture, and I repeat that there are 5 longitudinal arch and 1 transverse arch. So the lecture is over. Thank you for your attention. See you again. Bye bye.